I wanted to start with this saying that was taught to me as a very naive, very young staff nurse in my first staff nurse placement, which was that if you treat people like idiots, they'll behave like idiots. And it was my very first placement as a staff nurse in the general medical ward in Reading, working in a very small ward with a very large charge nurse. And I mean large in stature, but also in personality. And he was one of those guys who actually could physically himself lift the patient from the bed himself and not need any of the hoists or any of the other things. That didn't really need us either. But he also had real disdain for what we now would know as evidence-based practice and just thought, if you're going to do it, you're going to do it. And I learned so much from him, even though at the time I thought it was all a bit scary and what the hell am I doing here, because he actually had this real philosophy, which was that if you're going to treat people like idiots, then that's what you'll get. So our mantra has to be that you try and bring out the best out of people, that you try and get them to do things that they wouldn't necessarily think they could do, or that they would even think about doing for themselves, but that they would somehow have some inane sense that they could actually do it. And I learned a huge amount from him in terms of taking risks. I made more mistakes than I probably would care to admit. And there were probably a few patients around who suffered at my hands because of the fact that I was let free on them at a time when I knew very, very little. But what it did do was send me away with a real thirst for actually knowing more about how to work in the way that he was and how to get as big as him, but that was never going to happen. But also, it really made me think about how do we learn. And frankly, it probably disabled me, because from there on in, anything that was about linear thinking, thinking in a box, putting people in a nice, neat role like we are here, and getting them to think about what it is they should be doing was really just out the window, because of course that wasn't how he operated, and it wasn't how he helped me to operate and become an effective nurse. The irony, of course, as I was reflecting when I was cleaning the freezer, is of course I have then spent about 25 years doing precisely that, which is lining nursing students up in classrooms and teaching them, and hoping that they'll come out as these wonderful staff nurses. And of course we have seen the results of that most recently in some of the major scandals that have been in our healthcare system, where we have gladly blamed nurses for not doing the right thing and knocked them down. And even yesterday there's been a survey from one of the big recruitment agencies that now demonstrates that nurses are one of the least satisfied professional groups, which is a tragedy to think that that's how nurses actually think. And I blame it, a lot of it, on the idea that we actually treat nurses like idiots. We actually don't treat them as thinking, feeling human beings, but we expect them to do thinking, feeling human things. And so the idea of personhood is something that I have been working with and trying to understand for many years. And I've been trying to understand that through understanding my own personhood. Who am I as a person? What is it that makes me do the kind of things that I want to do? What is it that makes me want to think in the way that I want to think? And why the hell is it that I'm not just happy doing those routine things that everybody else is doing and always wanting to try and do them differently? I first encountered the idea of personhood when I was doing my teaching course at the University of Surrey, when we were all sent on a Rogerian-based facilitation program for a couple of weeks. And one of the facilitation programs was we turned up to this room one morning, all 15 of us, and we were met at the door. We didn't quite know what it was we were going to, other than it was a human potential session, and had no idea what that actually meant. And we turned up at the door to be met by a member of staff who said, "Give us all your clothes." And it was one of those moments where you thought, okay, do I or don't I? And you can probably imagine about 7 did and 8 ran. I was one of the 7 who stayed, and besides learning 50 different ways to hide my groin from other people, I did learn a lot about that whole idea about being naked and seeing self and who are we and how do we work together without all of the trappings that we bring into the different situations that we're bringing in. And I learned a huge amount about my own vulnerabilities, my own insecurities, and the kind of things that I wasn't prepared to do, and the kind of places that I wasn't prepared to go, both in my own practice as a teacher and in my own practice as a nurse. Subsequently, I ended up working in Oxford in a unit. And there, I was still trying to understand this idea of me as a person and as a nurse, and how did I actually connect with people in a way that was somehow effective. And whilst I was there, I was helping this older woman in a bath to have her bath. And at the time in UK nursing, there was a raging battle going on about whether district nurses should be doing baths with women at home, or whether that was really a social care problem, whether that was something that could be done by people who had no qualifications and all they needed to do was to do the bath. And I was thinking about this, and I said to this woman, so do you consider this to be a social bath or a therapeutic bath? Because I'm meant to be doing a therapeutic bath, but I'm not quite sure if it should be me or it should be healthcare. What do you think about this bath? And she said, I'll tell you what, love, it'd be a lot more social if you were in here with me. And it was one of those defining moments. Because of course she was right. It probably would be a lot more fun for her if I was in that bath. But it also said a lot about the kind of things we were neglecting in her care. Because, of course, even though she was in her late 80s, she was still a sexualized woman who still, I like to think, noticed that attractive young man, and actually wanted to engage in that way. But, of course, it was the blending of this. And finally, in that unit, was a wonderful nurse who by the name of Di Disley. And I use Di Disley to epitomize everything that I think we should value in human beings who are good nurses. And she is both a physical manifestation of that for me and a metaphorical manifestation of it. Di Disley was a nurse who I met when I started in this unit. And this unit was interesting because I was asked to go there to set up a department of academic nursing. I still don't know what that is. And that was in 1991 because the Department of Academic Clinical Nursing somehow had a little bit of a contradiction going on. And so we never quite got the Department of Academic Nursing, but we had a lot of good clinical practice. And I met Di, who was this amazing technical nurse. By God, was that place clean. Every patient was tidy and right by 10 o'clock in the morning, and everybody knew where they were. And I spent the first 6 months trying to unravel all of this because it was the antithesis of personhood. It was absolutely not respecting people as people. It was everybody was well cared for, but actually they were not being treated as people, either the staff or the patients themselves. And in the first 6 months, I decided that I would just work with people and try and get to know them and see could I shift their thinking a bit away from this kind of rigidity that was evident. And after 6 months, and trying not to actually top myself in the process, I was absolutely burnt out. And it was a very large ward unit, and it was very exposed. And just one day, I stood in the middle of this ward, and I started to cry out of sheer frustration. Because I was not getting anywhere, nobody was with me, they were working against me, it was just going absolutely nowhere. And I just started to cry out of frustration. And it was a bit like the parting of the waters, because suddenly there was not a single person to be seen anywhere on that ward floor. And there I was, grown man, meant to be the leader, standing in the middle of the ward, crying and thinking, oh shoot, this is not a good place to be, and how the hell do I get out of here? And from behind the curtains came Di Disley, who broke ranks with the group, who thought, no, I've got to help. And she came out from behind the curtains, she took my elbow and she walked me out of the ward just to help me and to get out of there. And that was the turning point in the whole progression of that unit in terms of how we changed into a unit that was absolutely rigid and fixed in the way that we did nursing practice to one that actually genuinely connected with people as human beings. And the turning point came because suddenly I understood me as an authentic person. Suddenly I could cry. I wasn't just the academic brought in to change practice. I was real, I was engaged in this practice, I was working alongside, and we made amazing changes. I did think 5 years later we'd probably gone too far when I came into the ward, and we had by then got rid of uniforms. We had done all the things that we weren't supposed to do in the 90s. And I opened the door of the ward to find Di Disley walking down the ward, or should I say skipping down the ward, in a fluorescent blue leotard. And I said, what the hell are you doing? She said, I'm doing the drug round. I went, right, okay. Because they had decided that actually we really needed to let the patients see us as human beings. And 5 of these primary nurses used to go to an aerobics class, so they said, let's bring our aerobics into the work. And so they all put on their leotards and worked in their leotards for the day and integrated aerobics with the work. Maybe it was a bit far, but I think the patients quite enjoyed it. But what that also said to me was this idea of psychological safety. And one of the things that I've learned from doing transformational development and research work is that unless we create settings that are psychologically safe, then we will never create the kind of practice that we want to create. And there's a very good literature about what is it that helps us to be psychologically safe. And fundamentally, it is about us being accepted, that we are accepted as the people we are, that we're accepted in that setting as skilled, knowledgeable human beings who have a connection with other human beings, and that we have an interest in what it is that we want to do, that we can take risks without being judged and lambasted for doing so, and that somehow we are making a significant contribution. My greatest lesson in psychological safety work has been with one of my PhD students who did a wonderful PhD with a very complicated intervention that now, when I present the work on her behalf at times, people go, really? And the intervention was an hour per day where staff came together to talk. How magic was that? And what we actually did was once a week and moved into being once a day, these staff came together to talk about their practice because we were trying to change pain management for older people. So we didn't have surgeons who believed that pain and knives went hand in hand, but actually to try and work it out that actually people could have a better experience. And the intervention was essentially to get people together in what Habermas has called a communicative space, a space where people can dialogue without fear, a space where people can say things without needing to be judged, a space where people can say the kind of things about their practice without recrimination. And it created a kind of an ethos that was genuinely person-centered for those participants, and which interestingly has managed to live on. And I was drawn back to this, thinking about what's gone on in UK nursing and healthcare over the last year, 2 years with the various scandals, and thinking about how psychologically safe did many of those nurses feel in places like Mid-Staffordshire. How psychologically safe did those nurses way back in the 90s in the Bristol inquiry actually feel, to be able to say the things that they want. Is more regulation, is more inspection, are more quality standards, are more protocols going to make them feel safe? Absolutely not. But communicative spaces where they feel they can connect with other people in a meaningful way is really going to help them. And for me, the essence of that is human flourishing. We spend a lot of time educating nurses and helping them to see the importance of evidence and of research, but do we really help them to flourish as human beings? Do we really help them to see that what they have as a unique human being is the essence of what they bring to the caring situation? Do we try and shape that and remold it, or do we try and help them to bring it into the present and to really work it in a way that is the real expertise of their practice? I believe we are doing that in much more creative ways than we ever have done before, but actually, unless we help people to flourish, then we will never get to the kind of caring practice that we really want. The essence of that is to move away from this language of having person-centered care to one which we have person-centered cultures. Cultures that actually enable everybody's personhood to actually flourish, to be present, and to be in the situation where they are actually at. And one of the books I've been reading recently is by an Irish psychologist called Margaret Gaffney, who I think quite geniusly wrote a book called Human Flourishing, funnily enough, at the height of the Irish economy crashing. Because, of course, everybody wanted to know how to flourish out of it, and therefore became a bestseller. And that was a real trick, I think, to actually have a best-selling book, is to do it at a time when nobody's any money, because then they'll want to know how you get it. But Gaffney has, I think, put into sharp light, really, some really interesting ideas that I think we need to pay more attention to in terms of how we flourish as caring people, how we flourish in care relationships. And firstly, she says, is we have to be autonomous. We have to have some sense that we have a control over our own destiny. We have to have some belief that I'm not just part of some machinery that is on some great zeal and that I'm just a cog in that wheel, that I must feel somehow that I have some control over what it is that I'm actually doing. She also says that I must feel connected, that there has to be a sense of connectivity, that somehow I need to feel connected with other people. So in our teams and in our relationships, do I genuinely feel connected, or do I feel slightly out of it? Do I feel that I'm being controlled by the other manager? Do I feel that things aren't quite right in the way that I'm engaging? How connected do I feel with other people? She also says that we have to be challenged every day, and that every day we have to have some challenge in our life that we rise to, that we embrace, and that we work with. And that challenge is not about causing us stress and causing us ill health, but it is the thing that makes us want to go that extra mile. It's the thing that makes us want to be the person we really want to be. And finally, she says, which I believe is the most neglected part of a lot of what we do with nurses currently, is that we need to embrace our valued competencies. And she's not talking about educational, behavioral competencies here. She's talking about our life competence, the competence that we've been hearing about in a number of these TED lectures, that people bring with them their whole life experiences that helps them to be the kind of person we want to have. And I think the challenge for all of us is how do we create the kind of practice settings that help all of us to flourish as human beings, whilst at the same time knowing there is a direction of travel we're trying to get to. And that leads me to think about how we actually do this. I've been working in transformational research agendas for over 25 years and have developed models and all of that stuff that we as academics are meant to do. And last year in some work I was doing in Canada, essentially was told by some of the participants you could make this a lot simpler, you know. And yeah, I think they were probably right. And during our creative work, because we use a lot of arts and creativity in helping people to think slightly differently about how to see the world, they said there were really 5 things that help people to transform. And one of those is that truth. We need to understand truth. Of course, there's no single truth, but we need to have some collective sense of what it is that we're really, really all about, to be honest, to be real. There has to be a sense of trust, and that without trust, we have nothing. And that as nurses and as team members, if we don't have that, and if you don't help us create that, then all of this other work is just meaningless. There has to be a sense of respect, that I need to be shown that I am respected as a human being. It's not just good enough to say, yeah, we respect you all, but I need to be shown it day by day, that what I'm doing is of value and that I'm respected for it. I'm respected for it even when I have got it dramatically wrong, that I'm still respected for having taken that risk. And that I have to be authentic, that going back to the idea of me crying in the middle of that ward, that that's an okay thing to actually do. That actually we need to see the real people underneath these uniforms, underneath these mantras that we carry around with us, and actually use these realness to shape the kind of work that we want to have. And lastly, that we have to be collaborative. The idea of co-constructing our reality and not being given a reality that somehow I'm expected to fit in is something that we come across all the time in our work. People given a reality they expect to work in and somehow expected to own it in a way that then makes it their own. And the reality is they don't. They will not own it because it does not resonate with where they're at as people. And more recently, I've been thinking about this in the context of research. And how do we actually get that transformational agenda into a kind of research context? My day-to-day job is managing a large program of research and trying to work with all of the infrastructure and construction around all of that work. But increasingly, as I engage in my own work, which is very much transformational research, and then the work I'm doing in terms of managing a large business of research, I see huge dissonance between what's going on within those things. And that came to the fore for me last year when I took myself away with a colleague and friend who I do a lot of this work with to a Buddhist retreat centre in the furthest point south in Ireland. It kind of falls off the cliff next up America, to a retreat centre to actually write and meditate. And we intermixed throughout the day periods of meditation with periods of writing. And one thing that was amazing to me was that in that 5 days, I managed to write 15,000 words, when most days I'm kind of sitting thinking, how the hell do I get another 500 words into this paper? And it just flowed because of the kind of space that was created in that. But also, it started to raise for me, how are we actually helping research to do this work? And it challenges me as a person doing this kind of work to hold on to my own personhood. For example, at the moment in my own research work, I rarely use the 4 papers that have come out of that work because they're a bit wacky and a bit different and I don't want to be judged. And so my own personhood is still on a journey, still being found, but I think stronger than it has been before.